Hello and welcome to the Alabama Public Health Training Network. Thank you for joining us today for our program, Aerodigestive Problems When It's Hard to Swallow and to Breathe. I'm Kay Melnick, Chief Nursing Officer at the Alabama Department of Public Health. Today's program is produced and provided by the Alabama Department of Public Health, Health Media and Communications Division. The expected learning objectives of the program are to review the basic mechanisms and causes of dysphagia in pediatric patients, to explain recommended treatment approaches for dysphagia in children, to recognize when feeding modifications may be indicated, to understand the utility of other therapies like surgeries and intensive therapy in pediatric patients with dysphagia, and to review when patients would benefit from an aerodigestive consultation. There is no commercial support or sponsorship for this program. There will be no endorsement of products displayed in conjunction with the activity. If you have a question about anything being discussed today, please call or email during our broadcast. The phone number and email address are on your screen now and will appear again later in the program. Also, the handout, sign-in sheet, and evaluation are all available online. You will need to register for this program in order to access these materials. Continuing education credits that have been approved for nurses and social workers for today's program. In order to receive credit for this training, you must watch the entire program, then complete and return the sign-in sheet and evaluation. While content may continue to be relevant, CE credit will only be awarded for 2 years, expiring on April 30th, 2028. If you are watching this program on demand and want to receive a social work CE certificate, you will need to complete the social work test and send it in, along with your sign-in sheet and evaluation. If you are watching this program live, there is no social work test required. For social workers, if you're watching this program live, it qualifies for classroom hours. If you're watching on demand, it is considered non-classroom hours. Distance learning conference participants who are not employees, contract employees, or retirees of ADPH will pay a fee to receive continuing education certificates for this program. And now I would like to welcome and introduce our presenter as we get started. Dr. Guillermo Beltran is an assistant professor of the Division of Pediatric Pulmonology and Sleep Medicine at the University of Alabama at Birmingham. Welcome, Dr. Beltran. I know you have a lot of great information to cover, so let's go ahead and get started. Thank you.
Okay, thank you. So we're going to talk about aerodigestive problems today. And I'm going to start with, well, I think we've already mentioned the objectives, but we're going to try to comment on the main causes of dysphagia in children, what do we recommend for them, how can we modify how we feed children to try to prevent some of these problems, and then more of the more complex therapies that we can use and what we can offer in Birmingham with our aerodigestive program. The first thing I need to start with is some definitions. And I have to clarify that I am a pulmonologist, but most of this work is done by speech pathologists and gastroenterologists, and we work together. So you're going to get the version from my perspective today. And I always say like the poor man version of what happens when you cannot breathe and swallow at the same time. But the two main terms that I'm going to use along this presentation are aspiration and dysphagia. And the main difference is that when we talk about aspiration, is anything that's foreign material that goes into the lungs, meaning that it passes the vocal cords or vocal folds. So it could be a toy, or it could be food, or it could be gastric contact from vomiting. All of those could be instances of aspiration. Whereas dysphagia is any difficulty or abnormality in your swallowing. So if you cannot chew well because of some dental problem, you may have dysphagia. There's one specific type of dysphagia that is more strongly associated to aspiration, and we're going to talk about that in a second. So there are several types of dysphagia, but oropharyngeal dysphagia is a term we use to problems pushing the food towards the esophagus towards the food pipe from the mouth. And when we cannot coordinate that kind of like procedure well is when things can go into the vocal cords and into the windpipe, the trachea, and you end up aspirating them. Sometimes you can even aspirate without you realizing that you have aspirated, and many babies do that. And that's what we call silent aspiration, meaning that food can go into their lungs and they may not cough or choke or react to it. And you may not notice that it has happened until you have consequences from it. There are 4 phases of swallowing, and they're typically divided by where they happened. And I think I have a picture of that. Yeah, so the first 2 happen in the mouth, and they're called the oral phases. And then the next one is the pharyngeal phase, which is the one that we're more concerned about. And finally, the esophageal phase, which is just taking the food or liquid all the way down to the stomach. And so based on this, we clarify that there are 3 possible types of dysphagia depending on where things happen. So a good example is someone that, let's say, has had a stroke and has some muscle weakness around the mouth and cannot chew well, will have a problem in their mouth, not being able to chew well and then swallow those, let's say, pieces of meat. That's oral dysphagia. If you have trouble drinking liquids because every time you drink a liquid it goes the wrong way and you choke, then you have probably more pharyngeal or oropharyngeal dysphagia. And then finally is esophageal dysphagia. That's more of a topic for the GI doctors. Like if you've had a tumor in your chest and your esophagus has been damaged, then food may get stuck in your esophagus, and that's a third type of dysphagia. I'm going to focus more on the oropharyngeal one, which is where you take your food or liquids from your mouth into your esophagus. Now, one important thing is if this happens, how will the children present to us, doctor, nurses, physician assistants? And I think there are 2 big boxes, although there's always some overlap. So the aspiration syndromes, I'm going to describe them in the next slide. And then some kids will have dysphagia and may not manifest respiratory problems, but may manifest more feeding problems, which could be that they have difficulty feeding, difficulty gaining weight, and what we call oral aversion, which is just a refusal to take bottles or to nurse. And what we think is that sometimes if there is silent aspiration, so if food is going the wrong way, although the patient or the kid is not coughing or choking, it may be uncomfortable still, and so they will just know to reject food because it's, in some way harming them. And then the aspiration syndromes I referred to are the pulmonary aspiration syndromes. And I think there's like 3 main ones. The first 2 I'm not going to talk much about today. But the first one there is aspiration pneumonia, pneumonitis. That's when you in one instance, let's say, because you vomited and you were for some reason not completely conscious, a large amount of that content goes into your lungs. And so it can cause a chemical reaction that then ends up in a lot of inflammation, or it can start growing bacteria, and that's the difference between pneumonia or pneumonitis. But that's like an acute problem that could happen to any of us, but most commonly in patients, let's say, that have had strokes or have cognitive problems or weakness. Then you have the classic foreign body aspiration. The most typical thing is that a kid was running around with something in their mouth and then they swallowed something and it landed in the lung. So I'm not going to talk much about those acute problems, because what we see most often is something sometimes we call aspiration bronchitis, which there's really not a clear name for it. But in adults, what you see is a diffuse inflammation of the airways and the lungs from the constant small spillage of food or liquid into the lungs. And our pediatric patients may actually present with just a cough. So they just cough and cough and cough, and there's no clear indication of where that cough is coming from. Some patients do have asthma because asthma is extremely common, but it is very difficult to control or is not responding to the typical treatments. And sometimes it's just that the inflammation is there and it takes a virus to really unravel a lot of more inflammation. And so those patients present with recurrent episode of what we call bronchiolitis, which is this lower respiratory tract infection in infants that many times ends up in a hospitalization to help them. So I have here some common clinical scenarios that we can go over. So let's say a 9-year-old patient that has severe developmental delay and cerebral palsy vomited, and then had hypoxemia, so low oxygen levels, fever, and a chest x-ray that is showing opacities, like concerning for a pneumonia. So that's a clear case of an aspiration pneumonia. If you have a 2-year-old that has cough and unilateral wheezing with hyperinflation of one lung particularly, you could think that maybe they aspirated a foreign body. And so those are more acute cases. But the ones that I want to talk more about today are a 20-month-old that has asthma that it seems difficult to control, and then there's this, casual comment that they choke on bottles frequently, or a 9-month-old that also chokes on bottles but otherwise doesn't cough. It's just happy but chokes. And then sometimes a 4-month-old that is just having a hard time finishing bottles. We don't understand why. And then sometimes it starts to just refuse them, like it's losing interest, and maybe that eventually starts affecting their weight. So all of these common clinical scenarios, sometimes we have to suspect that there may be some dysphagia and there might be some aspiration causing the problems. So if I think that this could be the problem, how do I confirm it? So the first thing is that you have to suspect it, because if you don't suspect it, you're never going to test for it, and you can easily miss it. Eventually it could get better, but it could also just not get better and would end up with the child being very sick. The easiest way is to have a speech therapist evaluate the child, and that's often probably the best first step. The problem, and we'll talk about it later, is that not always it's obvious to the eyes, even to the trained speech therapist, that there could be some aspiration. So that's when you need some confirmatory tests like a video fluoroscopic swallow study, which we often refer to as a swallow study or a modified barium study. A FEES, which is fiber optic endoscopic examination of swallow. That is a endoscopic exam, so they actually pass a scope in a child, and it's done while they're awake. And then if you don't have a speech therapist or the ways to do a confirmatory test, sometimes you just have to do some modifications on the feeds that maybe will help, and then that may give you the diagnosis. So when we do a swallow study, which is the most common test we do, what we give the children is liquids typically that are mixed with contrast, and you're going to see under x-ray if they're going the right way. And so it's as simple as that. And if the liquid happens to go close to the vocal cords and doesn't go completely into the lungs, we call it laryngeal penetration. But if it goes past the vocal cords, we call it aspiration. And basically, aspiration and laryngeal penetration are almost the same thing. Some people may think that one is more mild than the other one, but they're almost the same thing. So the nice thing about this swallow study is not only that you're going to confirm that things are going the right way, or wrong way, sorry, but also that it typically is done in conjunction with a speech therapist or any other type of therapist that then can change some of the ways that you feed that child. And you can confirm that there is a way, an alternative way, that may not cause aspiration. So it's both giving you a confirmatory diagnosis, but it may also give you a treatment option. The challenge with the next one, which is the FEES or the flexible endoscopic evaluation, is that you have to pass a scope through the nose of a child that has to be awake and eating while you're doing it. So not all children are able to tolerate this. It's extremely useful when you can do it, because again, you can provide food or liquids with typically a very clear dye so that you can see if it's going the wrong way. The nice thing about this test is that you're directly visualizing the vocal cords or vocal folds. And so if you suspect that there is a problem with the vocal cords, then this is probably the right test to do. And it can be done by some ear, nose, and throat doctors, but some speech therapists or other therapists are also trained to do them. So I think all of these tests have their like pro and cons. I think the speech therapy evaluation is probably the first test you're gonna do, but remember there is something called silent aspiration, where it is not obvious that the child is aspirating when they're eating, so it could be easily missed, particularly with a speech therapist that is not that well trained in children. And then the other, requires some more complex level of care. The swallow study is very easy to achieve. It's very well tolerated until the children get to like 2 years of age, and then they don't want to participate. The fees is not very well tolerated, but sometimes it has to be done. And then we'll talk about the empirical trials of modifications. But so you suspect the problem first, then you may confirm the diagnosis. And then I think the next important step, and often something that the family wants to know, is then why is this happening? And so this is, again, the simplified pulmonology version of how swallowing works and where the problems come from. So for me, right, so on the left we have the muscle and the nerves, the vocal cords, and the normal anatomy of your airway and GI tract. And then on the right side, you have the external factors, or we could call them that, like the volume of the liquid that you're going to drink, the flow, which is how fast it's going, and sometimes also just your breathing pace. And so there needs to be a balance, if you think of it, of both of these for swallowing to go properly. So just to give a very gross example, if a newborn is fed from a cup and chokes, what was the problem? And so the muscle, nerves, vocal cords, all the anatomy is probably fine. It's just that we probably have like a large volume and the flow is too much. And so it's impossible for a newborn to drink a large volume of liquid, and that's why they choked. If we have a 4-month-old that is on high flow nasal cannula for bronchiolitis, meaning that they are having a hard time breathing and they're probably breathing fast, and there's a good amount of oxygen going through their airway from the high flow support, and they take their regular bottle but they choke, then we can assume that, again, everything intrinsic to the patient is fine, is that their breathing currently is really fast, and probably even their normal cup or normal bottle they cannot tolerate. Similar situation, a 5-year-old drinks from a cup an hour after general anesthesia and chokes. So this patient probably still is under some effect of anesthesia. So the muscle and the nerves are not working 100%. Same as walking, right? It would be very difficult probably for this person to go run an hour after general anesthesia. But this is what we want to understand. A 6-month-old coughs and chokes with every bottle unless they're using an ultra preemie nipple, so like extremely small nipple. So in this case, it seems like the patient is choking, even if you're using the appropriate volume, the appropriate flow, the breathing is not affected. So that's when we start thinking, is there anything intrinsically wrong with the patient? Are the muscle and nerves working well? Are the vocal cords working well? And is the anatomy normal? And so, again, once we confirm that diagnosis and we know that the patient has trouble swallowing and that some of those liquids are going into the lungs, we go into what caused it. And then I think this is the perfect time to talk about our center, right? So we have a multi-specialist center with 3 pulmonologists, 3 GI doctors, 3 ear, nose, and throat doctors, 4 speech pathologists, 2 nurses, a dietitian, and a social worker. And the idea is that many of these patients could have a pulmonary problem, could have a GI problem, do have a swallowing problem, may need procedures from an ear, nose, and throat and doctor, may need procedures from a GI doctor. And so what we want to do is just, instead of them having to see each of us separately and going multiple episodes maybe of anesthesia to try to figure out what's going on, they just see all of us at once, and we can do coordinated care and try to see them all at the same time, get to a diagnosis more rapidly, and just improve resource utilization. And that's a graph of our numbers and how they keep going up and up, because I think more people in the community find us helpful. So when patients come to us, again, we go with the same mindset of if something could be wrong, it could be in one of these places. So it could be your muscles or your nerves, and so we think about neurologic problems, which could be primary or secondary. We think about prematurity or in utero drug exposure, because those are both very associated sometimes with difficulty swallowing. Sometimes we think about these brain malformations like a Chiari malformations or tumors or strokes, although those are very, very, very less likely in children. We think about your vocal cords because vocal cord paralysis is a clear diagnosis. For that, you would have to have some risk factors though, so it's very uncommon. And then we think about the anatomy, particularly the posterior tracheal wall, so that wall that divides your breathing pipe from your food pipe, trachea from esophagus. And we want to make sure that the anatomy of that wall is normal. And then, of course, sometimes we have to think about the breathing because some patients with floppy airways like laryngomalacia or that have a clear upper airway obstruction will have trouble breathing, and that will cause the trouble swallowing. So how do we do this? So the first part and the most important part for me is that for all neurologic abnormalities and all neurologic or other problems, the main test for us is the neurologic exam, the developmental milestones, and then some dysmorphic features. So actually this first part can be initiated by any pediatrician or any other provider locally, right? So if the patient has a normal neurologic exam and is meeting all developmental milestones, you've already ruled out probably a grand majority of the problems that we never want to miss. Probably for the other possibilities, we need more testing. But one of the things I always say for the vocal folds, if your voice is normal, then they are probably normal. So if you see a child in the office and they're talking and crying and it's normal, then you can probably already rule out that the vocal cords or folds are working. And then for the anatomical problems, those in the posterior tracheal wall, unfortunately, those do need an evaluation in the operating room under general anesthesia, and that's what the program is basically built for. But we're going to see who needs that and who can wait and have it done later. Now, while we try to understand what is going on and why the patient is having these problems, we're also managing all the consequences that can come from not being able to swallow and breathe well. And the most important one is probably nutrition. So we really don't want anyone to have malnutrition. And sometimes that means fortifying feed, sometimes means alternative ways to feed them. But that is one of the most important things for us. Of course, we want to prevent any foreign body aspiration. We want to prevent any aspiration pneumonia. So we're very cautious on what we let our kids eat and how they're going to eat it. We want to control the chronic bronchitis. No one wants to be coughing or in the hospital all the time. And even if it's risky, we want them to have some maintenance of oral skills, meaning that even if a patient cannot drink well from a bottle, we want them to continue to practice it because babies will often just lose those skills. We also value quality of life. Many of our patients are patients that have severe weakness or severe impairment, but that, you know, for their birthday, they want to taste a little bit of their cake, and that is okay if we feel like it's safe enough. We want to control the dysphagia symptoms, meaning that we don't want them to choke all the time. That's very uncomfortable, and some of our patients even choke on their saliva, and that's very, very uncomfortable. And talking about saliva, we want to control it because sometimes it can also harm the lungs, or it can cause constant choking, or sometimes it's just more of a laundry problem when it all comes forward. So again, if we think that this balance between muscle, nerves, vocal cords, normal anatomy, and the volume, flow, and the breathing is a problem, often the way to handle dysphagia and aspiration is to try to modify some of these. So if you choke because the drink comes too fast, then one of the easiest way to control things is to make them go slow. And so this is one of the most common things we do. If we give you thicker liquids, the flow is reduced, you get less volume, you get less dysphagia, and we may prevent or reduce how much you aspirate. Sometimes, particularly in small babies, we don't even have to modify the liquid. We can just change the nipple that they're using or the technique for nursing or do some pacing. And again, it's the same principle of less flow, less volume, less dysphagia, and less aspiration. So how do we do this? There's this scale from the International Dysphagia Group that basically is telling you how thick liquids can be. And it goes from 0, which is just a regular liquid like water or milk, and it goes up the scale as it gets thicker, all the way up to a number 4, which is extremely thick, which is almost like a puree. But we often can play along this scale because patients will do better with thicker liquids that they can easily control. I often tell families that it's as if you were trying to control a liquid with your hands. It will be much easier to control something that is thicker than just running water because it will just slip through your fingers. So some of the examples for what we call thins is most formulas. So most formulas out there in the market, breast milk and water and juice, they're all within the thin category. Then we go to the slightly thick category, and some anti-reflux formulas may fall under this category, but most of them are going to be in the first one. And then you get mildly thick, which was previously called or referred as to nectar thick, and then moderately thick, which previously was called honey thick, but it was causing some confusion, so it was changed to moderately thick. So what is the evidence research-wise for this? So I think as expert opinion, the evidence is vast. Every year we have an Aerodigestive conference that's nationwide, and every year we get together to discuss things, and every center in the nation is using thickeners to prevent or treat dysphagia and aspiration. I think we also have some radiographic evidence that I think is important, and endoscopic evidence, which is that when we use thicker liquids, typically on the swallow studies, the liquids don't go to the lungs anymore. So that's one type of evidence. There have not been many large studies done in kids. Most of them are done in adults. But many studies use it as a goal, meaning that there are many studies that are going to test an intervention like therapy, and the goal is, can we get you off the thickener? And so, although they're not saying that thickener is working directly, indirectly they're saying that, you know, that's the kind of like standard of care. There's not a lot of evidence in that they prevent respiratory symptoms, but our experience is that it is really sometimes all is needed and a very good first step. Now, there are some things we should know about thickeners that I think is important to educate all providers on. So breast milk, unfortunately, cannot be used with the most common thickener that you use in infants, which is cereal, because breast milk has enzymes, and those enzymes will digest the cereal. And so even though if you add cereal, it can get thicker, the degree of, you know, how thick it can get is very variable because it will depend on the enzymes on the breast milk. So we don't typically recommend mixing breast milk with cereal. Now, for cereals that you can use rice cereal, oat cereal. A lot of people are preferring oat now. But then there are also commercial thickeners that are, most of them based on xanthan gum. And unfortunately, there's some risk in premature babies of necrotizing enterocolitis. They were very isolated cases, but there's still a black box warning for some of those commercial thickeners, and they cannot be used in young babies. Gel mix is a type of mixing gel that is the one that can be used with breast milk, and it's not associated to enterocolitis, but it's very, very difficult to handle. Some families are able to do it, but it involves very specific steps of heating and waiting and all of those things. So one thing to remember for us is if there is risk of necrotizing enterocolitis, which for us is someone that was born prematurely or someone that is less than 1 year of age, we typically use cereal or one of the gel mix type of thickeners for breast milk. If there's absolutely no risk, then what we prefer is cereal for formulas and then commercial thickeners for breast milk or later. Medicaid currently does approve some commercial thickeners. It did not used to be the case, but some private insurances still do not approve thickeners. So it is often, out-of-pocket cost for the families. And again, some anti-reflux formulas may have some variable degree of kind of like thickeners, but it's not always consistent. Another way to reduce the volume of the flow, of course, is to just say you can no longer drink by mouth, NPO. And we try to not get to this point, but sometimes we have to. And so many times when a baby has a swallow study, or even older kids, we just, even on the thicker end of the spectrum, on the moderately thick and extremely thick, the liquid goes the wrong way and it ends up in the lungs. And so we call those patients the patients with no safe swallow liquid consistency. And it is often a challenge. At Children's of Alabama, it used to be this way, that if there was no safe swallow on a study, the patients would go to the emergency room for an admission. And then they would be admitted to a team where a hospitalist will have to discuss with the family what to do and what would be the next steps, which often involve the placement of a nasogastric tube or just a straight to surgery for a gastrostomy tube. We have created an alternative pathway now where if a patient has one of these results, they call us immediately, and we try to set up an appointment with them within the next 10 days. Typically it's within a week. And in that visit in clinic, we can discuss what do we think is going on, what are the risks of continuing to drink by mouth, what could we do to reduce those risks or prevent some of the complications, and what testing needs to be done before we decide on saying you can no longer eat by mouth. So we've had some very good results with these programs. We've doubled the patients with this severe degree of dysphagia that came to our program. We decreased the stay in the hospital by 1.5 days. And then we decreased actually the number of patients admitted to the hospital because of these by 60%, because we were able to have some discussions just in clinic and probably with the right people involved, considering not only the risk for the lungs, but also the risk for nutrition and for quality of life, and even just for like day-to-day care. So the caveat is that a very high number of these patients end up having some sort of global developmental delay, and actually swallowing may be the first problem that they show. If we think of it, let's say a patient with, trisomy 21, we know that they're going to be slow to some of the milestones like walking or talking, but swallowing could also be considered a milestone, and you may not be able to swallow yet until later in life. We have a small number of patients that also have anatomical problems with this, so we often can also coordinate procedures. And then the important thing for us is that a safe consistency is found eventually in about 50% of infants with this problem. So many times we can just wait and we know that things are going to get better, and now that family and that child has a team that they can reach out to if there are problems, and that will monitor them along that journey until they have a better way to feed. And so going back to this slide, so we've talked about the volume and the flow, but there's also some theory that if we work on the muscle and the nerves, maybe we can achieve a better swallowing. And for that, there have been some approach of like, maybe if we do therapy or stimulation of some nerves and muscles, we will end up with better swallowing and less aspiration. The main thing that has been discussed has been electrical stimulation of some neck muscles. But unfortunately, large studies have shown that it's really not that useful in pediatric patients. it has been very useful in adults after they have a stroke. And I think the thought process is basically that those kind of like neurological pathways and processes were already there and we're just recovering them. Whereas in children, some of these pathways are just not even there by the time we see this patient. So it's not what we currently recommend. It's probably harmful, but it doesn't have a lot of backup so far. And then we go to normal anatomy. And I think that's one of the things that us as a Aerodigestive program can really help with. So the idea, of course, is if you have a normal laryngeal and an esophageal anatomy, you shouldn't have aspiration. So this is the trachea seen from behind, and that kind of like black problem in the back of the trachea is what we call a laryngeal esophageal cleft. So it's an open communication basically between the trachea and the esophagus. And a type 1 is on the left, a type 4 on the other end, meaning that a type 1 would be a very, very small cleft. A type 4, basically, you don't have a wall that protects your airway. So the only way to look for this tiny defect is to put the kid under anesthesia, put a camera down down your mouth all the way down to the larynx, and then probe it with a metal rod. And that's something that our ear, nose, and throat doctors do. And so one of the things we often do in this clinic is who can have this and how can we help them? There have been multiple studies that show that if you have this problem and you get a procedure to try to fix it, your swallowing will get better. Now, the first data show that basically if you get the procedure, you get better, and if you don't get the procedure, you don't get better, as much. However, often the question from the family is not only if you're going to get better, but how fast are you going to get better? And so some of the research we have done at Children's of Alabama has, been around this. And what we've noticed is that not everyone gets better immediately. So this is a percentage of how many patients got completely better to the point that they could just drink and eat normally 2 months after the procedure, 6 months after the procedure, and 12 months after the procedure. And the darker bar is the kids that have the milder cases of dysphagia, whereas the lighter bar is the ones that had a little bit of worsening dysphagia. And so we know and we understand this better now, knowing that it's not only that you're going to get better, but it's going to take time until you get better. And it's also going to be based on how bad your swallowing was at the time of the procedure. However, we also look at a group of patients, and that's the group of patients on the right, that although they had a problem like a laryngeal cleft, we didn't do anything, and they got better on their own. So up to like 28% of those patients still were able to just eat normally 6 months later, even if we didn't do anything. So based on that, we created an algorithm based on these like 3 principles, which are that patients with a small cleft and very mild dysphagia may get better on their own without us doing anything. That a surgery or a cleft repair is not a guarantee of immediate improvement, and that the severity of the dysphagia, so how much help you need before, predicts how much you respond to the surgeries. So based on that, we basically assess kind of like what are the risks of this patient just getting better on their own, and what are the risks of those patients just actually needing a procedure to get better. Some of the other procedures that we may have to discuss, if you have a neural problem like a Chiari malformation in your brainstem, sometimes you may or may not need a procedure because not all of those patients improve immediately. If you have floppy airways like laryngomalacia, sometimes you may need a surgery for that, and we can also help evaluating with the ear, nose, and throat doctors for that. And then if you have what we call an H-type TF, meaning a fistula from your trachea to your esophagus, that's just allowing food to go from one way to the other, then typically you do need a procedure, and that ends up with immediate resolution of the symptoms. Moving on to controlling the aspiration and bronchitis and bronchiolitis. So we know that we can prevent some of these problems using thickeners or modifying some of your food. We know that we may need to take you to the operating room to look for some of these problems. But then if you have chronic cough or you have asthma that is not well controlled, we also may need to do something extra for that. And unfortunately, there's not a clear study showing you what's the best way to control for these symptoms. So what we do as pulmonologists is we use a lot of the asthma therapies that are available, because at the end of the day, most of those medications fight inflammation. And that's what we think is going on. We think that food or liquids or formula is constantly spilling into your lungs and is creating some mild to moderate inflammation constantly there at baseline every day. So we can use inhaled or nebulized steroids the same way that we would use in asthma. Sometimes we have to use azithromycin, which is most commonly known as an antibiotic, but it also has some anti-inflammatory properties, and we can use it for a very long term, and it has a very good safety profile. We used to use a lot more acid suppression, but acid suppression is not that indicated anymore because it's really not reflux many times that is causing the problems, and it's not acid reflux that is causing the problems, it's just the reflux in general sometimes. If you have a lot of saliva and that is causing aspiration, or it's just spilling constantly, sometimes we can also help with that. So there are some tests that are based on nuclear medicine to confirm that it is saliva what's causing the problem. We rarely use those. But there are multiple medications that we can use, particularly on patients that have some sort of neurologic problem, to reduce how much saliva they produce and just help with the quality of life. And those are atropine drops, glycopyrrolate, and sometimes scopolamine, which comes in patches. Some patients may have more of a long-term problem, and so we can use more procedures to help with that. And so Botox injections are very commonly used with variable response, although they do need to be reapplied every so often. There's a drool procedure where they ligate or remove some of your glands, and then more extreme interventions like separations, which we're not going to discuss today. So in summary, for some of these patients, right, so how do we diagnose those patients? We do swallow studies. We do the fiber optic endoscopic evaluation if we need to. We do speech therapy assessments. Once we have a confirmatory or we suspect strongly that this is the problem, we need to think about why they are having that problem, and you have to start with a good exam and a good history, and then sometimes we need to put them under anesthesia and do the scopes. And then for management, typically reducing the flow or thickeners is all you're going to need. If you have to go to the extremes of not letting them take anything by mouth, we can always help. We need to treat the asthma or the pulmonary problems, and of course we need to maintain good nutrition, oral skills, and quality of life. And then if we do find a problem that explains why the child is having swallowing difficulties, then we try to see if we can intervene on those problems and just make everything better. So I wanted to, kind of like finish with a case of like an example of the typical child that comes to us. So we have a 6-month-old that comes for a checkup, and they say that sometimes they choke with feeds, and sometimes they are stopping taking bottles because of that. So the first thing is that if a child is choking and then is starting to show some refusal, you have to at least consider that there could be some dysphagia and aspiration problems. And so again, the first step is going to be to confirm it. And you have all these tools, probably the first one being a speech therapist evaluation, and then the second one, but also very accessible, is a video fluoroscopic swallow study or a swallow study. So once you confirm the diagnosis, again, then we start thinking about what could be going on, and you're going to start with your neurologic exam, which let's say in this case is normal, and then your developmental milestones, which are as expected. And then you think maybe it could be a vocal cords, but the voice is completely normal, so very unlikely. And last, posterior tracheal walls, which is not something that we're going to ask people to rule out on their own, but those are some situations of like, maybe you can send those patients for referrals. Now, even if there is an anatomical problem, Remember that even with a very small anatomical problem, some patients will just get better with time. So it's never an urgent referral or never like a life or death situation where they have to be seen the next day. We can wait and we can see how things go. We have this algorithm on kind of like how long we wait. I'm not going to go into much detail on this, but basically, if the symptoms are well controlled, meaning that the patient is not choking all the time, not coughing all the time, if nutrition is very properly managed, meaning that the patient is growing adequately, the patient is able to eat by mouth, and so they're keeping oral skills, and is able to drink and eat with the rest of the family team, maintaining quality of life, we can wait. And then eventually we do say, what happens, let's say, 3 months from now? And so let's say that the patient has very good control of the respiratory symptoms, is getting great weight gain, there's no more signs of aversion, then we say, maybe if this patient goes under anesthesia, we can look for anatomical problems. But if the patient doesn't go under anesthesia, we can wait. And so who should come to our clinic? It should be patients that need to be worked up for why they aspirate. And again, that is after the basics of they have a normal exam, they're meeting all milestones, the voice is normal, there's no clear reason why they aspirate. If a patient has uncontrolled respiratory symptoms, they can always come to our clinic. If they have severe malnutrition or severe aversion, and we think it's because of this, they can come to our clinic. And if we think that this is a patient that is at a point where we have to rule out an anatomical problem, of course, we can help assess that and set up procedures. Whenever a patient is referred to our center, we review every referral as a group. Oftentimes, we have to say that the patient actually doesn't need us, but they need more a GI doctor or an ENT doctor or one test before they need us, or they just need us, and then we schedule them. So we're happy to review some of referrals if anyone thinks that they need to be discussed by us. I think that's the end, so we can move to questions.
Or did we get okay. We have some time now for questions. If you have any questions that you would like to ask, now is a good time to send them in to the email address on your screen. Thank you. Okay, this concludes our program for today. So I want to thank our presenter, Dr. Beltran. Thank you very much for that wonderful presentation and for being here. And we thank everyone for watching. Thank you.